Hello, this is Ania Gonzalez, and this is the oral presentation for the scholarly project. My scholarly project was about suicide screening in the outpatient behavioral health setting. This was a quality improvement project. I would like to thank my scholarly project committee, including my community person, Alfonso Morales, for his support in the completion of this project. It would have not been possible without him. Because of my background as a psychiatric nurse practitioner, I decided to select suicide risk screening as the topic of my scholarly project. Suicide remains a significant public health concern and is one of the leading causes of preventable death worldwide. Individuals receiving treatment for mental health disorders, particularly those with the diagnosis of depression, bipolar disorder, schizophrenia, substance use, and anxiety disorders, are at a substantially higher risk for suicidal ideations and suicide attempts than the general population. Early identification of suicide risk through standardized evidence-based screening is essential for implementing timely interventions, improving patient safety, and reducing suicide-related morbidity and mortality. The DMP scholarly project was completed at a site where there was no standardized process for routinely completing suicide risk screenings using an evidence-based instrument. Screening practice, of course, varied among the different providers, and this resulted in inconsistent documentation and the limited ability to monitor compliance with organizational and regulatory expectations. This practice gap highlighted the need to implement a standardized suicide screening protocol using the Columbia Suicide Severity Rating Scale, also known as the CSSRS. This was supported by provider education and ongoing performance monitoring. The quality improvement intervention for the DMP project addressed a significant practice gap in which the organization, an outpatient behavioral health clinic, lacked a standardized evidence-based process for routinely assessing suicide risk among patients receiving mental health and substance use services. This resulted in inconsistent screening practices. The scholarly project focused on the implementation of the CSSRS as an evidence-based screening tool. The primary aim of the DMP project was to improve provider compliance and accurate administration and scoring of the CSSRS through staff education. The project sought to answer the following clinical practice question. In outpatient behavioral health staff, how does the CSSRS training impact safety outcomes such as the presence and severity of suicide risk, referral to a provider, and safety follow-up planning compared with no training? This project was significant because the standardized screening process had the potential to improve early identification of patients at risk for suicide, facilitate timely intervention, and establish a sustainable framework for ongoing suicide prevention efforts in the outpatient behavioral health setting. In order to complete the project, literature review was done through the Ovid Synthesis platform. 10 primary articles were reviewed and synthesized, and the evidence showed that increased suicide risk is a significant health issue for individuals with an established mental health and/or substance use diagnosis. Literature also showed that 90% of individuals who die by suicide have a psychiatric illness, with the most common ones being mood disorders. And recognizing suicidal ideation in patients, which presents a crucial opportunity for a thorough evaluation to understand their challenges, needs, and risk levels. Literature also showed that the prevalence of suicidal ideation was 25.8%, with suicidal ideation rates particularly high for those individuals with personality disorders, PTSD, and depression, and for those with alcohol and sedatives compared with other substances. An additional primary article review yield that suicide attempt history was positively associated with years of polysubstance use, prior drug treatments, and unintentional overdose history. For patients receiving mental health care, it is recommended to complete routine suicide screenings and to implement preventive measures. A primary article found that out of 11 recommendations, 5 are relevant and action oriented and optimizing the quality of care for suicide prevention. Those included screening for suicidal thoughts and behavior, safety plan, early follow-up on discharge, continuity of care, and involving family members or significant others. The Columbia Suicide Severity Rating Scale, or CCSSRS, is an evidence-based tool appropriate for inpatient, outpatient, and emergency room settings. The DMP Scholarly Project focused on implementing a suicide screening tool in the outpatient behavioral health clinic. The Plan Do Study Act, also known as PDSA cycle, is a practical project implementation framework and a valuable tool for continuous improvement and implementation. The framework was selected for this scholarly project because it is a four-stage process designed to learn, adapt, and implement changes systematically. The framework is widely used in healthcare to effectively test, improve, and implement change. It allows for data-driven changes to be evaluated and refined before making broader implementations. During the plan phase of the cycle, the principal investigator identifies a goal or problem that needs improvement and develops a plan to test the change. During the do phase of the cycle, the plan is implemented on a small scale and the principal investigator documents what happens during this phase. Proceeding to the study phase, the principal investigator analyzes the data collected and compares the actual results with predictions to learn what worked and what didn't. Finally, the principal investigator decides to adopt the change, make revisions, and run another cycle if refinement is needed, or to abandon the change if it did not lead to improvements or resolutions for the issue identified. Based on the cycle, the DMP scholarly project followed the phases below. Problem. It was a regulatory noncompliance related to unestablished process to routinely screen patients for suicide risk. The plan was to develop a plan to educate clinical staff on the use and administration of the Columbia Suicide Severity Rating Scale, an evidence-based suicide screening tool. The do phase was to test the tool implementation with clinical staff in the outpatient mental health clinic for a period of 8 to 10 weeks. During the study phase, it was necessary to track the tool administration rates and patient outcomes and referrals after increased suicide risk was identified. The principal investigator was to analyze whether outcomes improved. Finally, during the act phase, if successful, the principal investigator was to roll out the screening tool hospital-wide and if not, to revise and retest. The Plan to Study Act framework provided a systematic approach for planning, implementing, evaluating, and refining the suicide screening intervention. During the planning phase, the clinical problem was identified, current evidence was reviewed, and a standardized suicide screening protocol using the Columbia Suicide Severity Rating Scale was developed. In the implementation phase, psychiatric mental health clinicians received education on administering, scoring, and documenting the CSSRS, and the screening protocol was integrated into routine clinical workflows. The study phase involved retrospective electronic medical record chart audits to evaluate screening completion, documentation accuracy, and the implementation of appropriate interventions. Finally, the ACT phase focused on the interpretation of the findings and identifying strategies to sustain the intervention, such as continuous staff education, routine compliance monitoring, and integration of the protocol into organizational policies. By following the PDSA framework, the project was able to systematically evaluate whether the intervention improved suicide screening practices and establish a foundation for ongoing quality improvement within the outpatient behavioral health clinic. This project utilized a quality improvement design with a pre and post intervention evaluation guided by the PDSA framework. The project was implemented over a 10-week period in an outpatient behavioral health clinic. Psychiatric mental health clinicians received education on the use of the Columbia Suicide Severity Rating Scale and incorporated the standardized screening tool into routine patient care. Data from 65 patient encounters were collected through retrospective electronic medical record chart audits to evaluate screening completion, documentation accuracy, and the implementation of appropriate interventions. Descriptive statistics were used to summarize the project's outcomes and assess improvements following implementation. A quality improvement project with pre and post intervention design was selected because the primary purpose of this project was to implement and evaluate an evidence based practice change rather than to generate new scientific knowledge. The project sought to improve an existing clinical process by introducing a standardized suicide screening protocol using the CSSRS. A pre and post intervention design allowed for comparison of clinical practice before implementation when no standardized suicide screening process existed with practice after implementation to determine whether the intervention improved clinician compliance, documentation accuracy, and appropriate follow-up care. The PDSA model was selected because it provides a systematic framework for implementing, evaluating, and refining practice changes in healthcare settings. The selected design addressed the project's inquiry by measuring whether implementation of the standardized suicide screening tool improved suicide risk screening practices in the outpatient behavioral health clinic. Comparing data collected before and after the intervention enabled for the evaluation of changes in screening completion rates, documentation accuracy rates, and the implementation of appropriate interventions based on the patient's identified suicide risk. The use of retrospective electronic medical record chart audits provided objective evidence of clinician adherence to the new protocol, while descriptive analysis demonstrated the project's effectiveness in improving compliance with evidence-based suicide screening recommendations. Together, the quality improvement methodology and the pre and post intervention design provided practical evidence that the intervention successfully enhanced the consistency and quality of suicide risk assessment in the clinical setting. The project evaluated 65 patient encounters using retrospective electronic medical record chart audits. Because this was a quality improvement project, descriptive statistics were used to summarize the data rather than perform hypothesis testing. Frequencies and percentages were used to describe clinician compliance with suicide screening, documentation accuracy, and appropriate interventions based on the patient's suicide risk. These descriptive measures provided a clear picture of practice changes following implementation of the standardized CSSRS screening tool. Since this project was designed as a quality improvement initiative, inferential statistical tests were not appropriate. Instead, descriptive statistics were used to summarize the data and evaluate changes in clinical practice following implementation of the suicide screening protocol. Frequencies, percentages, and compliance rates describe screening completion, documentation accuracy, and the implementation of appropriate interventions. These measures effectively demonstrated improvement in clinician adherence to the standardized screening process and supported the evaluation of the project's objectives without attempting to make statistical inferences to a larger population. The Quality Improvement Project demonstrated that implementation of a standardized suicide screening process significantly improved compliance with suicide risk assessment practices among outpatient behavioral health clinicians. Following implementation of staff education, integration of the CSSRS into clinical practice, and the development of a standardized follow-up process, suicide screening completion improved across the 10-week implementation period. Post-intervention results demonstrated improvement in the completion of suicide risk screenings, accuracy of documentation, and identification of patients requiring further clinical intervention. Clinicians demonstrated increased adherence to the evidence-based screening protocol, supporting the feasibility of integrating the CSSRS into routine outpatient behavioral health workflows. The implementation also improved consistency in suicide risk stratification and promoted the use of appropriate interventions based on identified risk levels, including additional assessments, safety planning, and follow-up care when it was indicated. Descriptive analysis of weekly screening data showed a positive trend in screening compliance and documentation accuracy through the project period. Variations in clinician completion rates were observed. This reflected differences in workflow adaptation, familiarities with the screening tool, and competing clinical responsibilities. However, overall findings indicated improved adoption of the screening process and increased reliability in suicide risk assessment practices after the intervention. In this slide, you can see some of the charts and tables that were used for the results. On the weekly suicide screening completion compliance rates post-interventions, you can see a consistent improvement in completion rates. At week 1, we had a 0%, and while we had some changes in completion compliance rates, during the last 3 weeks of the project, 100% was achieved. For the weekly suicide screening completion accuracy rates, you can see a similar trend, with week 1 being at 0%, and then you can see a consistent increase in the completion accuracy rates, going from 40% during week 2 to 100% from weeks 8 to week 10. For the total percentage value post-interventions, you can see that the overall follow-up compliance rate was 89%. Same thing for the overall rate of appropriate interventions that were implemented, 89%. For the overall screening completion, 89%. And finally, overall screening completion accuracy was 88%. Several limitations should be considered when interpreting the findings of the Quality Improvement Project. The small sample size, single site design, and short implementation period might limit generalizability and the ability to evaluate sustainability. Additionally, because this clinic did not have a previous standardized suicide screening process, baseline comparison data were limited. The project relied on descriptive analysis of EMR documentation, which provided insights into practice improvement, but it did not allow determination of statistical significance or long-term impact on patient outcomes. Despite these limitations, the findings demonstrate improved adoption of an evidence-based suicide screening process and support continued evaluation of the intervention. The findings of the Quality Improvement Project indicate that implementing a standardized suicide screening process using the CSSRS improved the consistency of suicide risk assessment practices within the outpatient behavioral health clinic. The findings suggest that the use of an evidence-based suicide screening tool combined with staff training and a structured workflow can enhance clinician adherence to suicide prevention practices. Improved screening completion allowed clinicians to more consistently identify patients at risk, appropriately document suicide risk levels, and initiate recommended safety interventions when it was recommended or indicated. Although the project did not evaluate long-term outcomes, the improvement in process measures demonstrates progress towards creating a safer and more reliable approach to suicide risk screening identification. Because this project utilized a quality improvement design, results were evaluated using descriptive analysis rather than inferential statistical testing. Therefore, findings should be interpreted as evidence of practice improvement within the project setting rather than evidence of causation or broad generability. However, the results support continuation of the CSSRS screening process as a sustainable clinical practice intervention. The findings indicate that implementation of the CSSRS improved compliance with suicide risk screening practices among outpatient behavioral health clinicians. Following implementations, clinicians demonstrated increased completion of required suicide screenings compared with pre-intervention period when no standardized screening process existed. The results suggest that providing education, establishing expectations, and integrating the screening tool into clinical workflows improved clinician adherence to suicide assessment practices. The implications of this project extend beyond improving a single clinical process. For patients, routine suicide screening promotes earlier identification of risk and timely interventions. For providers, the CSSRS offers a structured approach that improves consistency and confidence in suicide risk assessment. At the organizational level, the project supports patient safety goals and provides a sustainable framework for improving suicide prevention practices within outpatient behavioral health care settings. In conclusion, this project demonstrated a positive impact by improving the consistency of suicide risk screening practices among behavioral health clinicians. If I were to complete this project again, I would consider extending the implementation period, increasing the sample size, and incorporating additional outcome measures to evaluate the long-term impact of the intervention. Future evaluation could include monitoring trends in emergency referrals, safety plan completion, crisis interventions, and patient outcomes related to suicide risk identification. Additionally, ongoing staff education and periodic audits would be important to maintain compliance and support continued practice improvement. Moving forward, I plan to continue advocating for evidence-based practice changes that improve the quality, safety, and outcomes within behavioral health care. This project really reinforced the importance of identifying practice gaps, using data to guide decision making, and collaborating with interdisciplinary teams to implement meaningful change. The experience has really strengthened my confidence as a nurse leader and increased my ability to translate research into clinical practice. The DMP program has had a significant personal and professional impact on my development as an advanced practice nurse. Through this education, I have gained a deeper understanding of leadership, healthcare systems, quality improvement, methodologies, informatics, and the importance of using evidence to influence clinical practice. The process of completing this scholarly project challenged me to think beyond individual patient encounters and consider how system level changes can improve care for larger populations. One of the rare lessons that I learned through this journey is that sustainable healthcare improvement requires collaboration, persistence, and a commitment to continuous learning. The DNP program has transformed my role from simply providing care to becoming a leader who can identify effective solutions, develop a, processes to evaluate outcomes and advocate for safer and more effective healthcare practices. This experience has prepared me to continue contributing to quality improvement initiatives and advancing the future of psychiatric and behavioral health care. And with that, I conclude my presentation. It has been a pleasure.